Hi, Mahesh Thapa here again, and today I'm going to start a series of videos called A Cool Case, where I share with you some interesting cases I've seen on call or on clinical service recently. And we're going to do a little deeper dive into these cases, maybe talk a little bit more about the anatomy, the pathophysiology, my approach to cases like this, and make it a little bit more extensive presentation than just a case of this, a case of that, here's this finding, here's that finding. So hopefully you like this and I can share more of cases like this with you guys in the future. So let's get started with our first case. This is a 16-year-old male who came in with knee injury in a football match. And we can see that there is this bone fragment here, a chip of bone adjacent to the medial proximal tibial surface, the so-called reverse Segond sign. Now, the Segond sign is similar chip of bone on the lateral side, but when you see it on the medial side, it's called a reverse Segond sign. Now, a reverse Segond sign is associated with other internal injuries such as a posterior cruciate ligament tear, a posteromedial corner injury, and also an injury to the medial meniscus, which is part of the posteromedial corner injury. So let's see what we can find on the MRI on this case. The lateral view was not really contributory. I'll share with you anyway, except for some joint effusion. I don't really see very much on the lateral view. So now let's go on to the MRI. I'm going to bring up the sagittal proton density sequence on here and leave it there like that. I'm going to zoom up just a little bit so we have a nice big view of this. So on the left, we have coronal fluid-sensitive fat-suppressed sequence. Here we have the axial fluid-sensitive fat-suppressed sequence. And here we have a PD fat-suppressed sequence. Let's look at the axial images real quick. I'm going to go up really high and just go over a little bit of the anatomy. This is something you should be familiar with. On the medial side, you've got this sort of pes anserina complex, which is made up of your sartorius, your gracilis, and semitendinosus. Note the semitendinosus is always located posterior to your semimembranosus muscle. The semimembranosus muscle forms a myotendinous junction at the level of the top of the femoral condyle, and you can see that there's a little bit of edema here in that myotendinous junction. Not a lot of it, but just a little bit. So this tells me that some fibers of the semimembranosus muscle or tendon complex has been injured. The more edema I see here, the more the components are injured. There are several named components of the semimembranosus tendon. We'll go through a couple of them. It's not really that important to know all of them, but I'll tell you the two most important ones as we go through it in the anatomy. Again, here's the gracilis, and here is the semitendinosus back here. Here's the axial images. More anteriorly, here we see this thickened structure by the condyle, but the medial aspect of the condyle, and you can see it on the coronal view. It's this big thickened structure over here, and that's of course the medial collateral ligament, or also known previously as the tibial collateral ligament. Now this ligament gets thinner as you go posteriorly, and this ligament is now known at the posterior aspect as the POL, or the posterior oblique ligament. The posterior oblique ligament makes a turn around behind the femoral condyle, the medial femoral condyle, and when it makes this turn, it is then known as the OPL, or the oblique popliteal ligament. Now, it's sort of counterintuitive to name something with a popliteal in it on the medial side when we know the popliteus is a lateral structure, but this is sort of a fan-like thickening of the capsule, if you will, that goes from the medial aspect and goes all the way to the lateral aspect. So this is a way for the posteromedial corner to communicate with the posterolateral corner via this OPL, the oblique popliteal ligament. And that, again, is sort of the very posterior part of the capsule. It blends in imperceptibly with the capsule. At this level, we're pretty high up. You can see that the capsule itself is relatively thin. There's a little bit of connective tissue over here, but like the contralateral side, it's nice and thin. But as we go more inferiorly, this capsule is very edematous here, and it is thickened and has a lot of high signal, suggesting that there may be some injury to the posterior capsule on the medial side, okay? So those are the axial structures. Now let's go back one more time to the semimembranosus. The semimembranosus, as it comes down, gives off an anterior branch like this. That's called the pars reflexa. We're going to see that really well on the sagittal sequence. And as you go further down, a part of it extends out anteriorly and inferiorly, and that's known as the direct arm. Now, the direct arm should be darker than this. The fact that it has all this intermediate or high signal and looks sort of mushy tells me that there's probably some injury to the direct arm of the semimembranosus muscle. So those are the main structures that I really evaluate on the axial images when I'm thinking of a posteromedial corner injury. One final thing that I may look at, just because on this case I have this known reverse Segond fracture, is as I go to the axial, I'll go to that same level here as on the coronal view, and I notice that there's this edema in the tibia, and just adjacent to that, there's this area of low signal, which is probably the avulsed, over here, the avulsed fragment of bone that came off this part of the tibia. So now let's look at the coronal section. At the mid aspect, we notice, in fact, there is this medial collateral ligament, or the tibial collateral ligament as it used to be called. And as we go posteriorly, it becomes thinner. When it becomes thinner, we know this is the POL, or the posterior oblique ligament. And you can see that it does blend in with the capsule. In fact, some fibers attach to the upper part of that medial meniscus. This is the meniscocapsular ligament. There's an upper part and a lower part. However, the lower part is a little wavy, and this is the part that's attached to this part of the capsule and part that's attached to the medial tibia. So indeed, you can see that little piece of bone has been avulsed, and whether you call this an avulsion of the meniscotibial or the capsular tibial ligament, or attachments, deep fibers of the tibial collateral ligament, in essence, it doesn't really matter. It just means that there has been an avulsion of some kind of connection between your meniscus and your tibia, which includes the capsule. So it's kind of a capsular avulsion injury, if you will. So we said that this is associated with a posteromedial corner injury. So what are the components of the posteromedial corner? There are basically 5 that you have to look at and examine, and several of them we've already shown you, and I'm going to go through that again. Number 1, you're looking at the POL, the posterior oblique ligament. Number 2 is the OPL, which is the oblique popliteus ligament. We saw those already. You're also looking at the medial meniscus, particularly the posterior horn and the root. Number 4 is the capsule itself and the meniscocapsular ligaments. Those sort of come together as 4th component. And finally, the 5th component is the semimembranosus tendon. So we're going to take a look at that next. Looking at the sagittal image, let's go up here. This is our thick semimembranosus muscle. And remember, we said anteriorly it gives off an anterior branch, also known as the pars reflexa, and more inferiorly it gives off what's called a direct arm. And that direct arm should be a little darker than this. Remember, this is the area that looked mushy on the axial images. So that tells me that there's probably some type of injury happening to the direct arm. There are other named parts of the semimembranosus tendon. There's a capsular component. There's what's called a distal component. And there's one other component that I always forget, but those aren't as important. You can still see them sometimes, depending on the quality of the MRI and how lucky you get. But the most important ones you really want to pay attention to is this anterior branch, or the pars reflexa, and the one that goes a little further down, called the direct arm. Okay, so I think here the direct arm is injured. So that's the semimembranosus muscle. On the sagittal, you can actually get quite a nice view of the capsule. Looking at this sort of fuzzy stuff back here, that is the capsule. It's quite thick, and in this patient, it's a little edematous and thickened. And if we look again, there is abnormal signal here where the posterior body of the medial meniscus transitions on to form the root, and this is suspicious for a root tear. I'm going to show you an axial image. That's a DES, which stands for dual echo steady state. It's basically a gradient sequence. We acquire it in the sagittal plane isovolumetrically, 0.6 millimeter slices, and we can reconstruct it in any plane that we want. This one, the axial, is very helpful. We typically use it for cartilage imaging, but I think it's great to look at the anatomy of the meniscus with this also. This is the normal lateral side. Nice C-shaped structure of the meniscus. Here's the anterior root, beautifully seen. Here is the posterior body, the posterior root, also very, very well seen. Now let's go to the side of abnormality, which is the medial side. Here's the body, anterior horn, anterior root. You can see it comes down pretty nicely. You can follow it pretty well. Posteriorly, as you go around the horn posteriorly, there's abnormal signal at the very posterior aspect of that meniscal body. And as you go more towards the joint, there's high signal where that root attachment should be. So this tells me that there is a root tear of that posterior medial meniscus. So that's a really great way of looking at the shape and the anatomy of the meniscus, I think. So let's go ahead and put our sagittal proton density image back over here. Again, there's a lot of edema and high signal in that capsule and at the very posterior aspect of the capsule, which we said is the oblique popliteus ligament. So I suspect that there is some injury to the capsule and the oblique popliteus ligament. I can't say for sure that there's an injury to the POL, the posterior oblique ligament, because oftentimes it doesn't run in a top-down type of pattern like the tibial collateral ligament does. And if we look very, very carefully on the sagittal image, we can see some of the fibers kind of. Here, this big thick band anteriorly, that is your medial collateral ligament or your tibial collateral ligament. Very, very well seen. The POL or the posterior oblique ligament, it's located posterior to that, but it doesn't come straight down. It sort of comes in a triangular fashion, in a hash-shaped fashion down here. You can sort of kind of see some of those fibers coming down like this, the pattern over here. So it's hard for me to see if it's injured or not. It's probably not injured at this point because I can actually see some of the continuation coming all the way down. But this is where your posterior oblique ligament would be, just posterior and arranged in a sort of a hash-like, indistinct manner going from the top to the bottom, just posterior to your tibial collateral ligament or your medial collateral ligament. So finally, we said that the reverse Segond fracture is associated with a posterior cruciate ligament injury. And looking at the sagittal image, here at the posterior cruciate ligament, in fact, there's a lot of high signal. Over here, it doesn't seem to be completely continuous with our femoral condyle. So indeed, there is a high-grade tear of the posterior cruciate ligament. So what do we have here? We have components of the semimembranosus tendon injured, particularly the direct arm. We've got injury to the posteromedial capsule, perhaps to the oblique popliteal ligament, which is an imperceptible connection at the very posterior aspect. We've got injury to the posterior medial meniscus and its meniscal root. We have an avulsion of the meniscotibial or capsular tibial ligament as a little fleck of bone was pulled off. So I think the POL, the posterior oblique ligament itself, is intact. And so we have most of the components of a posteromedial corner injury, so that qualifies for me. In addition, we also have the other associated injury of a posterior cruciate ligament tear. So I hope you found that helpful. It was nice to go through the anatomy, talk about the different components, look at the injury, do a little deeper dive than we normally would. And if you like content like this, as I said before, please comment down below and let me know. And I'll definitely put more videos like this. Please don't forget to like the video and subscribe to my channel if you like what you see. We'll catch you next time.